Hello everyone, this is just another short video for a bit of revision on chronic myeloid leukemia this time. So just to recap where CML fits within the other myeloproliferative neoplasms and myeloid disorders. If we just have a quick look here at this image. So I've just created a table, myeloid disorders. Within that falls, a few other conditions, so AML, MDS, and then we have a category called myeloproliferative neoplasms. And a lot of the time when you've probably heard us talking about that before, it's largely in reference to these ones. So the Philadelphia chromosome negative classical MPNs, which is ET, essential thrombocytosis polycythemia vera, and myelofibrosis associated with the JAK2 mutation. But MPNs more broadly can be categorized in two ways, either Philadelphia chromosome negative or Philadelphia chromosome positive. Of the Philadelphia chromosome negative, you have the classical and the non-classical ones. Classical, is a completely separate talk. And then non-classical, I guess the only one that really should be known is systemic mastocytosis. And that one seems to be pretty a common exam question at the moment. Just one of the, they seem to test all the time, one of the mutations, KIT D816D, is the mutation so that may come up in the exam. But again, we'll just be talking about CML, which is on the Philadelphia chromosome positive branch, and that's in fact the definition of CMLs. So moving along, CMLs and MPN, as we discussed, it's from pluripotent bone marrow stem, and it's always associated with the Philadelphia chromosome mutation, which is the BCR-ABL translocation from chromosome 9 to 22. There's slight male predominance, but not really, and essentially what you get is expansion of the myeloid precursor cells in the bone marrow, and that causes sometimes symptoms and then other problems within your marrow. This seems to be pretty, I guess, a popular exam topic because, prior to 20 years ago, essentially CML was pretty much fatal. And then with the development of TKIs, it's more than 90% achieve basically a remission-like cure, or you manage to suppress the mutation for them to live, normal and pretty uncomplicated lives. Blood film, so you'll see a leukocytosis. The main feature that they'll usually mention in the stem is basophilia. So you will see lots of basophils on the film, or they'll mention it in the exam stem at some point. This is just a quick recap, I guess, of the history. As you can see, in the 70s, it was mainly just like hydroxyurea that was used. And then in the 80s, alpha interferon, and then it wasn't really until about 2000 imatinib came out, and that's pretty much changed the way that we treat this disease. The natural history of CML is triphasic. Initially, it used to be defined as chronic phase, accelerated phase, and blast crisis. But I think they updated the criteria in 2022 to say that there's just chronic phase, and then the other phase, blast crisis and accelerated phase, are sort of combined now as one. 40% of patients, regardless, are detected asymptomatically. They don't have any symptoms. If they do have symptoms, they'll be B symptoms, anemia, and splenomegaly. But sometimes you can just get isolated thrombocytosis or just presentation at blast phase without any previous sort of chronic phase. If someone presents in blast phase, it can be difficult to tell the difference between that and Philadelphia chromosome positive BALL. But if they're asking a question about CML specifically, they will mention like the chronic phase, or they'll say something about, or usually, use the term myeloid or MPN, or there should be something else in the stem to suggest that it's a myeloid disorder, and we're not looking at like acute ALL. Basophilia, again, is the main clue that you'll get in the exam stem. And sometimes in the question, if it says thrombocytosis and basophilia, and even, in cases of isolated thrombocytosis, often the BCR will be checked, because that's the thing not to miss if someone's got undifferentiated thrombocytosis. So we do just a peripheral blood test. We can check for the BCR-ABL gene on PCR, and generally you do a bone marrow to confirm the phase, and that's just to look for the percentage of blasts. So less than 10% is chronic phase, and then more than 20% is like blast crisis. Between 10 and 20%, you're in that sort of like accelerated phase, and you would treat basically at that point. There are a few prognostic scores that you can use to decide which TKI to commence, but they're, I guess, a bit complicated, probably outside the scope of what would be expected to do. But again, risk factors, spleen size, the amount of basophilia, the number of blasts, and then it's important to consider, the other medical comorbidities, because some of these are contraindications to some of the TKIs. So we have the TKI inhibitors. First generation imatinib, second generation dasatinib, nilotinib, third generation ponatinib, and then fourth generation asciminib. Good fact to keep in mind is that they're all metabolized by CYP3A4. The first and second generation are different to third and fourth. So I think you should think of first and second together, and then third and fourth together, just for the purpose of the test. When we look at the first and second line drugs, they have slightly different adverse drug profiles, drug effect profiles. So in imatinib, it'll be sort of like the skin rash. You can get some fluid retention, but you won't see the sort of pleural effusion and that really classic description of fluid overload that you'll see in questions that involve dasatinib. So when you use dasatinib, 30% of those people, there's a 30% risk of getting a pleural effusion, and that's related to the cumulative dose. It's not an absolute contraindication to using the drug. If you get a pleural effusion, you can re-challenge. If you're able to treat it, it's not too bad. But if you get recurrence of the pleural effusion, then generally it's recommended to change the TKI. And then nilotinib, you can see here the adverse drug effects, so LFT derangement, pancreatitis, prolonged QTc, etc., etc. Some of these may not be appropriate if someone's got a history of heart and lung disease, so just keep that in mind. Later line therapies, ponatinib and asciminib, important to know because these two are indicated on the PBS in the presence of the T3151 mutation. So if you have that mutation, you can skip straight to the later line third and fourth generation TKIs. Again, toxicities is listed, but really sort of the hot fact to know about this is the T315I. And in fact, all of the, now with the next generation sequencing, you can actually sequence for multiple mutations that these drugs may be susceptible to or resistant to. And in fact, there are some like uncommon mutations that we're finding now that are for example, susceptible to imatinib but not to um, asciminib or whatever. But again, outside the scope of what we can do for this. So goals of therapy, we use the BCR-ABL as a target. So you should be having therapy. If you're having therapy for 3 months, you should be able to get the BCR-ABL less than 10%, and at 6 months you want it less than 1%. And then 12 months and onwards, you want it less than 0.1%. And if you can't do that, then the drug's not working, essentially, and you have to look at something else. Generally, nilotinib and dasatinib seem to have a more rapid and deeper molecular response when compared to imatinib, and that's usually what we want to do. If you can't achieve these goals, then always adherence. You can test for mutations, and then you can try alternatives. Most people respond to one of them, and you should be able to get away without doing an allogeneic stem cell transplant. I think that's pretty uncommon now. Goals of therapy. So we want a treatment-free remission. About 20% can get up to that. So the criteria to attempt to cease the TKI is you have to have been on it for 5 years, and for the last 2 years you have to have had a deep molecular remission. So that is defined as the BCR-ABL is less than 0.01. So you have to have that for the last 2 years. And probably about 50% of people will not be able to remain treatment-free. They'll have to go back on the TKI, but that doesn't affect the therapy otherwise. If it's not working, you'll know after a month because the BCR-ABL will start doubling. Like if being off the drug is not working, that's what I mean. Yeah, allogeneic bone marrow transplant. Sometimes if people present in blast crisis, you kind of have to, you might, once you treat them, you achieve what we call a second chronic phase. So in the natural, based on the natural progression of CML, they should have started in chronic phase and then progressed to blast crisis, and by treating them, you get them into a second chronic phase. And then at that point, you can also consider bone marrow transplantation in addition to the other indication being that resistance to the TKIs. You can't use TKIs. You have to use interferon alpha, or you just observe. It's pretty unlikely. So if you are diagnosed with CML during pregnancy, depending on what's going on, you may be able to wait until after the pregnancy to start the TKI. So you just hold off, have the baby, start the TKI after delivery of the baby. If you already knew you had CML before you got pregnant, then you would try to achieve a durable remission-like cure and then come off the TKI for the therapy. So it's almost like a trial of cessation of the TKI. And then if it's not working, go back on it after the pregnancy. But there's pretty limited data on this, and again, probably outside the scope, but just an interesting fact anyway. So that's pretty much all that you need to know about CML. It's not too complicated, I think, and I think it's a pretty straightforward exam question. There are some key features that they should give you, and then the drugs themselves are very effective. So I think it's perfectly reasonable that they might ask you about the drug side effects and the way that they're used. But yeah, I think that's all. Okay, thanks.